those who embrace. Okay? But that is how I see you, how I work with you, how I believe is your life so is your belief system. No one goes into nursing for the money, and excluding what's going on over there, no one goes into Tamaki health nursing for the money. Okay? We are here for the people. Lorena, hate the mihi, I acknowledge you. Hate the mihi, I acknowledge you. Lorena, kuaio, no mai, tēnā koutou, Ariana, or most people know me as Ari. I am the Wellness Support Team Equity Lead, and I'm someone that you can call at any time within office hours to help and update me. Lorena, tēnā koutou, tēnā koutou, tēnā koutou.
Lorena, thank you so much, Ariana. Welcome everyone to the Tamaki Health Nurses Confrence. I'm just going to go through some health and safety with you first before we welcome Mark Bella to do the presentation. Can you guys hear me okay?
Oh my goodness. So if there is a fire, let's hope there isn't, everyone needs to leave out this door, out to the front of the building and meet in the grassy area. Please walk slowly, don't run, don't push anyone over. Our lovely team, Lola and the team will be helping take care of us today. Bathrooms are to the left. If for whatever reason you guys do need to pop out during the presentations, you are okay to do so. Just let one of our team know just so we can make sure you are all okay. Perfect. Just introducing myself, I am Natasha. I'm the clinical nurse educator for Tamaki Health. I have been here for quite a long time and I know most of you. Perfect. So just introducing Mark. Hello. Yes, please. So Mark is the CEO of Total Healthcare, and he is one of the most important people today alongside Lloyd, because he is the guy that funds all these amazing events for us and all the opportunities that we have for our nurses. He has been providing quite a few funding opportunities and just helps to kind of engage our nurses and is investing in our nurses to grow. Perfect. So hand over to you. I'll put your presentation up.
That's good. Thanks. Not too soon. Tēnā koutou te katoa, ina iri, ina mana, ina mate, ina whare, ko Mark Vella tako ingoai, ko te kaiwhakahere Total Healthcare, no reira tihei, mauri ora. Yes, so Mark Vella, CEO, Total Healthcare, PHO. So and I'd also like to adjust this a little bit. We're not the most important people in the room. You guys are, because without you guys, we're not in the room. So that's quite important to remember. Just to show of hands, if anybody knows which PHO they belong to. Yeah, I thought so. So most people at dinner parties I go to haven't got a clue what a PHO is, Primary Health Organisation, yet everybody is actually enrolled in one. Well, 95% of New Zealanders are. And what I thought I'd do today is just to run down very briefly exactly what a PHO is, but more importantly, what it means for you guys who represent the patients that are enrolled with us. And any minute now that will come up. That's okay. Oh, the other thing I must say, I am an ex-teacher, so I do understand what it's like to be remunerated not quite to what I thought my value was, but I did have a go at selling widgets and leaving the teaching profession for a while, and used to go home and my then wife used to say, so what are the stories you got today? And I'd go, well, I sold something that people didn't really need, but I got a company car and I got paid a lot more than when I was teaching. And then she would say, I miss the stories about how you used to change lives in the classroom. And I think it's a very similar analogy to nursing, where the country very much values the profession, and we're just working towards, and as a PHO, myself and my collegial PHOs are working very hard towards gaining a greater equity, not only to address the disparity, but maybe even get a better deal for those working in primary care. Okay, so next slide, please. Oh, we can lose locality network now, actually. There we go. Now this is the most important slide. Yeah, no, that's all right. too tech. So basically the structure is you've got the Ministry of Health, you now have Te Whatu Ora, that used to be DHBs, and Te Aka Whai Ora, Maori Health Authority, for the time being. And then you have the PHO, which receives all the capitation funding that the patients generate to your practices, but it also receives an amount of funding based on the number of Māori Pacific and those living in quintile 5 areas, and that's called the flexible funding pool. The funding that's generated in terms of the enrolment goes straight through the practices, so it just comes through our accounts straight into Lloyd's, and off to the Caribbean he goes. No. But the flexible funding pool is withheld by the board, an independent board of the primary health organisation, of which half are Pacifica. The chair is a Kaumātua, and there's Tamaki Health representation on that board as well. The amount of flexible funding we get is around $10 million, primarily because most of our patients enrolled in the 250,000 we've got are high needs, Maori Pacific quintile 5. That's quite a bit of money. That's a fair amount of chunk of change. And so it takes its stewardship very carefully. So we also utilise Tamaki Health for its management and clinical lead services. So nursing, the clinical governance forum, and also some of the invoicing, accounting, that sort of stuff. So the PHO itself is a little bit unusual in two things. This one is a little bit unusual in two ways. Most PHOs have a network of providers that are all independent businesses. I am the absolute envy of my colleagues because I have one. That's it. So I deal with one person, and we can affect change a lot more rapidly than other PHOs because they've got to negotiate with all their different providers. And the branding, of course, you actually work for them, local doctors in White Cross. That's an old slide. We're actually now 250,000 patients. Puts us about the 5th largest PHO in the country now. And maybe we're applying for a national status, which will actually increase that some more because there are now no DHBs. Next slide, please. Those are our demographics, as you can see. High needs, 56%, so the majority. That used to be about 80, but of course the more practices that come on board, that diminishes. But it still doesn't stop the number of high needs patients, which still generates that flexible funding. Next slide, please. That's its structure. So you've got the Board of Trustees, you've got a clinical governance committee that Lloyd is a part of, and nurses, and Richard Hume, Mahesh Patel, etc. We've got an executive committee which has representation, so Joanne and Reshmi are on that to represent nursing, and we've got an audit and finance committee which is really exciting. Okay, so, and then we've got those other advisory groups that we either have or are aiming to have. Next slide, please. This is stuff you already know, I'm pretty sure. So 1.5 million patient encounters per year, which is about 4,000 a day. It's a huge amount of people that you are coping with every day. And we've got 4,000 pregnant women per annum, largest provider to Pacific and Counties Manukau, and to 32% of the total Pacific population across Auckland. Are we recognised as a Pacific provider? No. Don't get me started on that. Okay. And we have 37,000 Maori, 21% of those residing in Tamaki Makaurau. So a lot of Pacifica and Maori patients are enrolled with us. we, as an independent study many years ago, showed that it's probably likely because it's accessible. Your service is accessible. It's low cost and it's extended hours. And this is what Pacifica and Maori like. They like to try and get the help when they need it and where they want it to go, as close to home. Next slide, please. And so this is where we get a bit interesting in terms of where that flexible funding has been invested and where it is being invested. So obviously the wellness support team. So there wouldn't have been health coaches without the PHO. There we go. So it was the PHO that invested in developing the health coach role way back. ProCare was developing the health improvement practitioner's role. And subsequent, dare I say it, now it is nationally funded and it's a national program. That came from the little acorn seed from Total Healthcare and the willingness of Tamaki Health to invest the investment we're giving them into the wellness support team, so more than just psychologists, but HIPS health coaches and AWHI oil workers. Vulnerable mums, so Mana for Mums and Best Start. Any Mana for Mum nurse here? No. Okay. This is a groundbreaking initiative as well, which has, it's very simple actually. We looked at developing services to support young Maori Pacific females testing positive in the clinics, and then we appointed a Mana for Mum coordinator, maternity coordinator for that. She came back and she said, actually, you don't need to actually create any services. There's an Excel spreadsheet full of them all around us. What we do need, though, is to connect that mum with those services. Been very successful. BBM partnership, so Lurd has been very busy beavering away with Dave Latally and Rob Campbell and developing a closer working relationship with BBM, not so much for the BBM, but for the From the Couch program, which works with morbidly obese. And you'll have seen on social media, no doubt, that the success that has been there. And so again, we're looking at supporting that being rolled out, not only in Auckland, but potentially nationally. Gandhi Nevis is also a groundbreaking initiative that is now also funded by Ministry of Social Development. That grew from the investment of funding from the PHO, using that flexible funding pool to support a service that works with perpetrators of family harm to keep the partners safe and their children safe. We've had over 2,500 families that we've worked with since 2014, and Massey evaluation that was presented in Parliament a couple of years ago highlighted the fact that we're achieving a 65% non-recidivism rate. Try saying that after a few drinks, recidivism rate. Okay, and so that's all part of the FFP. So just the next slide, we won't go through them all because we're limited for time, but these are the examples of what the FFP is invested in, including community liaison officers, Lorenzo, Fit Life, which is a boot camp, clinical pathways, free Wi-Fi in your clinics, that all comes from that flexible funding. Next slide, please. And then a lot of long-term condition support, Care Plus, of course, but discharge care coordinators, home visits, podiatry, etc. Self-management education, physiotherapy, BBM clinic there, of course. We're funding for a doctor and a nurse and a health coach to be in those clinics, because we're starting to realise that we talk about hard to reach patients, but actually it's hard to reach practice. So for the patient, they don't see themselves hard to reach. They see the service as being hard to reach. So we're actually flipping everything on its head and taking the services into the community. And that's what the PHO is developing. Next slide, please. That's a new one. That's very clinical. I don't understand that, so I won't go into it. And DCIP, also very clinical. Next slide. And yeah, as you can see, there are a lot of initiatives that are coming from that. Sexual health, immunisations. I'm trying to find the integrated care team, nursing academy, there we go, that's all part of this, right? And so on. I think that's the last slide. Yeah, near enough. Oh, there's the money, okay. So yeah, $10.3 million. But you can see now where it's going. And the other difference with this PHO is that every year it has submitted a business plan to the Ministry of Health and the then DHBs now to Whatuora. And it also produces an annual report as well that shows the results of those investments. So we've always been 100% transparent, and I think that is the last slide. Yeah, okay. So that's what a PHO is and does. It was a little bit under threat under the health reforms in 2019, 2020. As it transpires, we've shown and proven ourselves to be invaluable to the primary healthcare sector, and it is now looking like we are going to be around for some time to come. And this was my picture. Any quick questions? So I hand it over back to my learned friend here. No, that's good. Okay. Thank you very much.
Thank you, Mark. We really do appreciate you. Awesome, perfect. I'm going to now introduce our CEO, Lloyd, who's going to talk to us about the future of nursing within Tamaki. Putting you on the spot.
Can you hear me if I talk without the mic? Talk with the mic. Okay. Talk with the mic. Thank you, Ariana. Atamaria koutou katoa, ko Lloyd McCann toki ingoa, ko Cape Town toku turanga waiwai, ko Tamaki Makaurau toku kāinga, he pai ki te kou ki te ropu o Tamaki Haora. Morning everyone, it's a real pleasure and privilege to be here this morning with all of you. As Natasha said, I think the brief to me was talk about what's going on at Tamaki Health and apparently also about the future of nursing at Tamaki Health. We'll come on to that in a second. I'm a little bit unorthodox, as those of you who have met me out in the clinics will hopefully come to learn and come to know. So I'm gonna do things a little bit backwards this morning. You know a little bit about me, so I do want to take the opportunity to also get to know a little bit about you. So we're going to play a game. Indulge me a little bit. If you don't know, I am an emergency medicine doc by training and background. And one thing I do know from time spent in emergency departments is that when people come and attend conferences, they are awesome opportunities to learn, but they are also, unfortunately, great places to increase risk for DVTs. So I'm going to get all of you to stand up, please. Stand up, please. And we'll start as we mean to carry on. So whenever you do get a break, whenever you do get an opportunity, combat DVT, stand up, walk around, etc., etc. Okay, the aim of this game is to get everybody sitting down again, right? So I'm going to ask a series of questions, and this allows me to get to know you a little bit. If your answer is yes to the question, grab a seat. So the intent for me is to try and get everyone sitting as quickly as possible. Okay, so question number one. Who in the last 12 months has either themselves or with a family member attended a general practice or an urgent care facility? So if you have in the last 12 months, either yourself or with a family member attended a GP or an urgent care, sit down. Wow. Okay. Usually that gets everyone sitting down on the first go. This is clearly a tough crowd. Okay. Who of those remaining standing wears a wearable? So either a Fitbit or an Apple Watch or something that kind of tracks and monitors your sleep, how many steps you're doing in a day. It could be your mobile phone if you've got a step count on your phone. If you do have one of those, sit down. Yeah, clearly, really pushing me into my idea. Okay. Who, and I'm going to give myself a long time frame again, who in the last 12 months, for those remaining standing, has either at work or in the home environment Googled a symptom or a sign? Thank you. Okay. To take me 3 goes. Like I say, usually the first question gets everyone sitting down. And the reason I ask that question is, you know, we all come from diverse backgrounds. There is so much that unites us. And one of those things is actually accessing and taking care of both ourselves and our family members, right? Through engaging with services like general practice and urgent care. And as I say, I've asked that question through conferences throughout the world, and generally it gets everyone sitting down at once. So that's another lesson I think that's important for all of us. Mark showed it in the numbers that he outlined. General practice and urgent care touches thousands of lives every day. And I want you to really keep that in mind in terms of the difference you are making on a day-to-day basis for families across Aotearoa. Still going to go a little bit backwards. I'm going to kind of cover off some thank yous, very important thank yous next. I do want to start those thank yous by saying a huge thank you to Mark and to Kate. Tamaki Health would not be what it is were it not for Mark's leadership, Kate's leadership, and the awesome partnership we have with Total Healthcare. So a little bit weird and bizarre again, I am going to ask you to give a round of applause for Mark and THO. The next thank you is a thank you to you. So thank you for taking time out of both family life and working life to come and be here today over the course of the next 2 days. And importantly, thank you for all you do on a day-to-day basis for our patients and for our organisation. It is a huge, huge and incredibly important job that you all perform on a day-to-day basis. And again, as Mark said, it's not actually about me and it's not actually about him. It is about you because you are the glue that holds this organisation together. So a huge thank you to all of you. I often don't like singling people out, but I am going to do that. The next 2 days are going to be absolutely fantastic, I have no doubt. You'll see goodie bags on chairs that you're sitting on or underneath your chairs now. Awesome venue, amazing lineup of speakers. None of this would have come together were it not for that lady over there, Natasha. So please come forward, Natasha, and give Natasha a round of applause. Thank you. Thank you. I know that's a little bit embarrassing, but you've done an amazing job. Okay. So as I said, the brief was to talk about what's happening at Tamaki Health and what's happening from a nursing perspective at Tamaki Health. I'm going to answer that quite simply and quite quickly because, as I'm also one to do, I'm not going to talk about that for too long. The answer to that question in terms of what is happening at Tamaki Health is lots. Okay? I hope you are starting to see that. I hope you are starting to feel that out there on the shop floor and at events like this. It's sort of been an unprecedented time for the organisation, right? Before I joined, there was this thing called COVID that I think all of you lived through and experienced. It was a very good time for the organisation in terms of the huge impact and the difference it made, again, to the lives of many New Zealanders. But I think it was also an incredibly challenging time for the organisation as well. So I know we're all feeling a little bit tired. We're all feeling in some areas, as Mark and Ariana sort of alluded to, potentially somewhat undervalued. I hope some of the things we've been doing this year in terms of sorting out pay, and I recognise and acknowledge that there is more work to do in that space. And again, we're leaning on Mark's leadership to help us with that. But also, I guess, in terms of events like this and the educational initiatives we have put in. So last night we had another one. We've kicked off a CPD series that hopefully all of you are either attending in person or online for the organisation, because there is an acknowledgement and a real focus on ensuring that we do have continuing professional development opportunities for you all and for all of your colleagues. We're also focusing on ensuring that Tamaki Health really becomes the beacon for primary and community care, not only for nursing, but across the board in New Zealand. So, what are some of the things I am going to talk about very briefly because we do need to kick off into the actual program today? I wanted to talk about two things in particular, leadership and aspiration, okay? If any of you have met my wife, she will say that I am incredibly annoying because I'm what you'd phrase a relentless optimist, right? So I'm not going to talk about optimism because a lot of people will say sometimes people who are eternal optimists are actually somewhat delusional. They won't actually see the challenges and the problems that are facing them or facing an organisation or facing a system. I want to acknowledge that both we as an organisation and our health system at the moment have got a heck of a lot of challenges in front of us. I'm somewhat okay with that though, because of this thing called aspiration, right? So aspiration, in my view, is that connection of both hope and optimism. Yes, we need to recognize the challenges that are facing us, but given what this organization has achieved, given what you all do on a day-to-day basis, I have no doubt in my mind whatsoever that we are incredibly well placed to address and tackle all of those challenges and get our organization to be that beacon for primary and community care. Why I'm also comfortable about those challenges comes back down to this thing called leadership, right? When we think about leadership, we think about positional leadership quite often. So CEOs, Mark, the role I hold in Tamaki Helath, a CEO position. Leadership is about so much more than that. Leadership is about making a difference on a day-to-day basis. Leadership is about having difficult conversations with each other, difficult conversations with the patients we serve. Leadership is about addressing those challenges I alluded to earlier. Each and every one of you in this room and all of your colleagues out there are leaders in our organization. You are leaders on a day-to-day basis. You are making a difference not only in the lives of the patients you serve, but in the lives of the colleagues you work alongside. And I use that word colleagues, not just nurses, very deliberately, because you are integral not only to the nursing teams that you are part of, but to the clinical teams and the broader organizational teams you are part of as well. Because I do believe that everyone in Tamaki Helath is a carer. The cleaners, the practice managers, the receptionists, of course yourselves, the docs. Something that unites us all is the fact that we are all caregivers. However, the role of the nurse in the clinic, in the hospital, in the community, in a health system is an incredibly special and important one. So I'm going to come back to a point I made earlier. You are literally the glue that holds our clinics, that holds our organization, that frankly holds health systems together. And so we need a thriving nursing workforce. We need thriving nursing leaders. We need all of you to be the best that you can be, not only for our patients, but very importantly for our organization, and importantly for our system as well. So I would like, as you're going through the program over the next 2 days, for you all to kind of think about that. Many of you are incredibly humble, I know. Don't forget the fact that you are all leaders. And the magic really happens when you are happy and you are engaged in your workplace and engaged with each other, engaged with the patients, and engaged with the broader teams you are part of. So thank you again for all you do on a day-to-day basis. Thank you for coming here with an open mind, the opportunity to learn and the opportunity to learn from each other, but also from the excellent speakers we will have. And again, thank you all for being the leaders that you are and for making the difference you do on a day-to-day basis, and for the work you're going to be putting in to help us as an organization meet all of those challenges that stand in front of us. Nō reira, tēnā koutou, tēnā tātou katoa.
Thank you. Amazing. So we're going to welcome our first official speakers, Rachel and Romana, and they are from Auckland Regional Public Health Service, and they're going to be talking to us about the world of notifiable diseases.
Thank you, Natasha. Kia ora, everyone. My name is Rachel. I'm one of the public health nurses from Auckland Regional Public Health Service.
Kia ora, everybody. My name is Romana. I'm also from Auckland Regional Public Health Service.
Awesome. So thank you so much for the opportunity to speak here. Thank you, Natasha, for inviting us. I'm really excited to share with you all a little bit more about the world of public health and what our role as a public health nurse is. It's been quite a busy year for public health. With the borders opening, we've had quite a few incursions and outbreaks already, measles, mumps, pertussis, to name a few. So I think as a health sector, we need to all work together to control these diseases and prevent them from spreading in the community and harming people, especially the most vulnerable communities. So we'll get straight into it. So this presentation is really about exploring the role of public health and our role in investigating communicable diseases, which you'll as a GP, as primary care, notify to us. We'll cover some of the common communicable diseases which cause outbreaks, including clinical features and what public health action is actually taken. And throughout this presentation, I'm really keen if you'll have a think about ways that public health and primary care can work better and communicate better. I'm really keen to hear your thoughts and feedback on that as well. Cool, so going into the first section, which is Introduction to Public Health. So we'll have a quick look at the National Public Health Service structure. So we've all been unified, along with Te Whatu Ora, we've got the National Public Health Service, and then dive a little bit deeper into what is the role of ARFs in the Public Health Unit, and then finally, what do public health nurses do? Cool, so starting off with National Public Health Service. So prior to National Public Health Service, we had 12 separate public health units across New Zealand, and now we're all unified, so we can provide a more streamlined service and a more, cohesive public health service. And of course, we work under the Ministry of Health and partner with Māori Health Authority and the Public Health Agency. So there's now 4 regional public health services covering New Zealand, and Auckland is served by the Northern, sorry, I just got to get the right name right, the Northern Regional Public Health Service. So we've got our colleagues up in Northland, in Ngātai Ora, they're covering the Northern District, and we've got Auckland Regional Public Health Service covering Auckland. And that's the whole of Auckland, so that covers all 3 DHBs, so if there's any communicable diseases that need to be notified anywhere in Auckland, it comes through to ARFs. Cool, and then I guess one of the questions is, what is public health? So even when I tell my nursing friends or other, friends who work in the health system, I'm working in public health, there's often that question of what is public health exactly, which is an excellent question. So public health is a specialized area of health, and it's concerned with health protection, so preventing communicable diseases, health improvement, so prolonging life, and health promotion. And the key difference between public health and other specialties in health, I guess, is we've got this population level focus. So we don't do too much with we don't do any individual care or treatment or diagnosis. We leave that up to you guys in primary health and in the hospital. We're focused on that population health prevention sort of space. And that's just the very textbook definition of what is public health. And the mahi we do actually looks like this. So not sure how clear you can see all those icons, but the things that are highlighted in the light blue color, what the health protection team or the health protection space in public health do, and the things in the sort of dark blue borders are what public health nurses focus on. So things like health equity, outbreak response, TB control, and communicable disease control. Cool, and then just narrowing it down a little bit further, we work in the space called health protection, and just, it's not just nurses and doctors, just shout out to the massive team that contribute to protecting the health of our communities, health protection officers, medical officers of health, our Kaimanaki and Tatua cultural support teams are really key, so there's a whole team behind what we do. But of course, moving on to the public health nurses, this is just a nice little photo I found of the team. So our role is, as I think I've said a million times already, is focusing on communicable disease control and preventing and responding to suspected or confirmed vaccine preventable diseases or communicable diseases. And just a note here, if there are enterics or gastrointestinal diseases, those are still notified through the ARFs, but it's our health protection officers who deal with that. So yeah, I guess our focus is on investigating where this communicable diseases come from, where is it spread, and how can we control it spreading further. Okay, and I mentioned earlier that public health is focused with population health level, but as nurses we do get involved with individual care, so we sort of balance both sides of that. Great, so we'll move on to the disease notification process, and I understand it's the GPs that notify diseases, but I think it's just really helpful as nurses, just understanding the process. So really quickly touching on the Health Act, and I'm by no means a lawyer or anything, but this is the legislation that empowers health authorities to take public health action. And it means that medical officers of health have certain powers. They can issue directions and things like that. But we always work with our communities, work with our whānau, work with our cases to partner with them, and rather than going straight to the legislative side of things. But just highlighting that Section 3 and 3A outlines the legal notification requirements to public health, and then Schedules 1 and 2 just list all the diseases that require notification. And a lot of the work we do is, it's asking very personal questions, and some might say it's a bit intrusive. That's how someone might feel if we phone them up and ask them, where have you been, what have you been doing? So we always make sure that we keep privacy right at the center of the work we do. So we never will mention identifier information to contacts or to the public. Cool, so I'll pass it over to Romana, who will talk about the SHED team and the notification process.
Thank you, Rachel. So SHED, that's another team. So we get notifications either through direct lab notification or email or phone call, and in the future, e-referrals, where people refer through the RCP, Regional Clinical Portal. So when a notification comes through GP by those 3 or 4 means, we take the notification and process it, and then as a public health nurse, I start to do the interview. And if it's not a direct lab notification, I just start to interview the person using the notification form. So the notification form, you can find it through our website, Auckland Regional Public Health website. So you fill it out, fill it up, you can do it online, and then email it to us. All the details are on the notification form. Then you send it to us. Or if it's a phone call, then as a public health nurse or a medical officer of health, we complete the details for you and then send it for process while it's waiting for the result, for swab result. Or if it's a direct lab notification, it just comes straight as a positive result, then we start to act on it. So we are going to present the clinical presentation for the following diseases: measles, mumps, pertussis, aka whooping cough, meningococcal disease, Hep A and B, then TB. So I'll start with the presentation for measles. So we know that we just had, I think, 3 confirmed cases of measles over some few months or weeks. So the clinical presentation, as we can see, it's the incubation period starts around 10 days after being exposed, but with a range of 7 to 13 days from exposure, and transmission is airborne. And then the symptoms, first symptoms are fever, cough, runny nose, sore, and watery pink eyes. Then the next symptom, we'll see a blotchy rash. And that rash tends to start on the face, behind the ears, before moving down your body or the trunk. So the rash lasts for up to 4 a week. The infectious period is 4 days before the rash onset and 4 days after rash onset. And the laboratory confirmation is nasopharyngeal swab, PCR, which is taken within 7 days of rash onset. So for public health action, for us, if we receive a positive result, then we start to do contact tracing. Our contact tracing is asking the patient or case where they have been during their infectious period, which is 4 days before until 4 days after. Day 0, which is day the rash onset began. Then we check and see where they've been during that infectious period, and then we start to contact trace the people. So when our public health action is, we establish infectious period, as I said, in the incubation period. So the source investigation will be 21 days to 4 days prior to rash. And we isolate day 0, which is rash onset, 4 days before rash onset and 4 days rash after rash onset. Then we